We're going to move to our next presentation from our good friend J.D. Corl, who's going to talk about the newest in lithotripsy technology, the forward IDE pivotal and feasibility study. J.D., thank you for being with us today.
Thanks, Eric. Appreciate the opportunity to present this exciting data on the first clinical use of a novel forward-shifted, non-balloon-based peripheral intravascular lithotripsy system. I'm going to talk about the primary outcomes, 30-day outcomes of the forward IDE trial and the Mini-S feasibility study. Peripheral artery disease is associated with bad outcomes like death, amputation, myocardial infarction, and stroke. We know that calcification is common in peripheral vascular disease, especially in patients with advanced disease. These patients often have multi-level disease, thick, dense calcium extending into the medial space, and CTOs are common. Treatment of these lesions are associated with early recoil, dissection, restenosis, and need for revascularization. Successful treatment is dependent on proper lesion prep and calcium modification. There are some limits in treating calcified lesions with our traditional therapies, such as balloon angioplasty and atherectomy. There is limitations in effectively treating deep and medial calcification. There's risk of dissections, perforations, and embolization, and there's often an inability or difficulty crossing these calcified CTOs with the standard equipment. Lithotripsy does address some of these limitations. The pulses do effectively modify thick and medial calcification. There's low risk of vessel injury and embolic debris, but there's still that limitation in crossing with a balloon-based therapy. So the Javelin catheter is an IVL non-balloon-based catheter with a single emitter that is shifted forward near the tip, about 3 millimeters from the tip. It's delivered over an 014 guide wire. This is a non-balloon-based IVL therapy. On the left side, you can see our standard balloon IVL, where the tip is too far from that distal emitter to effectively treat the cap or that calcium at the tip with the pulse. You can see the radius of that pulse does not effectively reach the tip of that catheter. With the Javelin catheter, you can see that emitter is shifted forward approximately 3 millimeters from the tip, and that pulse does extend beyond the tip, so it can effectively treat and modify that calcium and allow for the catheter to cross. You can also see as the catheter crosses, it does modify that catheter in the process. I'm going to talk about the Mini-S feasibility trial and the forward PAD trial. Inclusion criteria, at least moderate calcification, Rutherford class 2 through 5. Stenosis below the knee was at least 70%, above the knee at least 90%. Lesion length was capped at 150 millimeters. Key exclusion criteria was cutting balloons, scoring balloons, reentry devices, or atherectomy devices, and in-stent restenosis was excluded. Primary safety endpoint was a composite of CV death, target lesion revascularization, clinically driven, and unplanned target limb amputation above the ankle at 30 days. Primary effectiveness endpoint was successfully treating lesion with less than 50% residual stenosis and no flow-limiting dissection. Here's a treatment algorithm. You can see there's 4 stages down the right side. First stage, the lesion has to meet the inclusion criteria as it relates to calcium, stenosis, and length. You have to cross the lesion with the wire. And then you move to the second stage, which is delivering the Javelin catheter. This was successful in all 100% of the patients. Only 2% required pre-dilatation with a balloon to help deliver that catheter. Then the third stage is device crossing. This is the most important stage. And in a fourth stage, you can see the mandatory post-dilatation and then potentially IVL therapy or destination therapy with a stent or drug-coated balloon. Here's our primary safety endpoint, 90 patients, 9 patients made it to follow-up. There was 1 death at post-op day 4, which was unrelated to the procedure. The primary effectiveness endpoint, 98 patients made it to the final imaging for evaluation. There were 103 lesions in the 90 patients. Baseline characteristics, this was an old patient population, average age of 74.5 years, mostly male. Diabetes were 56.7%. 2/3 of the patients were smokers. About a quarter of the patients had a previous myocardial infarction and bypass or stents, coronary stents in 36.7%. Prior peripheral procedures, 47.8%. Below-the-knee lesions represented 42.7%, severe calcification in 82.5%, and again, chronic total occlusions, 38%. Device success was 93%. This is crossing the lesion and successfully treating the lesion. There were one IVL balloon was used in 74%, one or more lithotripsy in 25.7%. Total number of lesions with stent implantation was 23%, and drug-coated balloon in 40%. Here's our primary effectiveness and stenosis reduction. You can see the MLD at baseline was 0.7%. After the javelin catheter, 1.7%, and post-dilatation up to 1.7 millimeters, and post-dilatation up to 3 millimeters. Final diameter, 3.5, with final imaging. The percent stenosis improved with each step as well. 83% stenosis at baseline, 59% stenosis following javelin, 31% with post-dilatation, down to 23% final stenosis, which is similar to previous balloon-based IVL trials. Here's your primary safety endpoint. Major adverse events at 30 days was 1.1%. Again, this is the death, which occurred 4 days post-op. There was no target lesion revascularization, no unplanned target limb major amputations above the knee. Here's the dissections, low rate of dissections, 1.2% following javelin catheter. There was 4.1% following post-dilatation. Again, this was a 1-to-1 post-dilatation, and the final images only had 1% dissection. There was no thrombus, no episodes, there was no reflow, no spasm, no distal embolization, and no abrupt closure. Here's a typical case that we saw in the trials. This is a left anterior tibial artery with a chronic total occlusion. You can see no flow down that AT. On the post-javelin images in the middle panel, you can see the MLD was up to 1.3 millimeters with the stenosis down to 37.46. So significant improvement with just the javelin therapy prior to any balloon angioplasty. Post-dilatation, final images showed an MLD up to 1.9 millimeters. This was with a 2.5 millimeter balloon, and your stenosis was 17.89%. So in conclusion, the javelin IVL catheter is a novel, non-balloon-based catheter with a forward-shifted IVL emitter designed to modify calcium to allow crossing and modify that calcium in the process. The forward IDE and feasibility studies of the javelin catheter met the pre-specified safety and effectiveness primary goals. The crossing success was 93% in a difficult lesion subset with a lot of calcium, older patients, 38% CTOs. 23% residual stenosis is similar to that seen in balloon-based IVL trials, and there was low angiographic complications. Longer follow-up is planned at 1 year. Thank you.
Eric, I'm just curious. I got mesmerized for a while by the emitters, and I wasn't listening for a second. So you use this to open up the first channel, but then you also use it to treat the entire length of it, it sounded like, because you're just using one catheter. So can you explain that a bit more?
So most cases were done with, in the trial, were done with one catheter. 8.6% of those cases required a second javelin catheter, and you saw about 25% or so actually used balloon-based lithotripsy to follow up. So most cases are being done with just the javelin, and correct, it does help cross the lesion by affecting the calcium, but as you're going through the process of crossing, you are modifying that calcium similar to what you see with a balloon-based IVL. And you can see that lumen gain, which was pleasantly surprising that you did get that lumen gain just with the javelin catheter. So before you even got a balloon down there, you were affecting the lumen size.
What's your time like if you're crossing a 10 cm lesion? Are you pausing to emit multiple pulses along the way? How's that run?
So good question. So the catheter, it's a 150 centimeter catheter. It's a 1014 wire system. You have 120 pulses total. There's 12 cycles of 10 pulses each with a 10-second break between cycles. So 120 pulses with that distal emitter.
Are you delivering them static? You're delivering them as you're driving through, basically?
Yeah, so you do advance slowly. It's not really a pecking. It's more of just a gentle pressure and let the lithotripsy affect the calcium so you can allow the crossing. And if you do get to a dense cap or a dense area, you can park it there with a little gentle forward pressure, and you may use more pulses in that area compared to, midsection through the lesion where it's going easier. But you do want to treat the whole thing. And 120 pulses should get you about 120 millimeters.
JD, great. This seems to be a great device coming our problem with the profile. I think I have a pretty same question about safety. How much can we apply? Sometimes I'm unhappy because I want to do more, but I don't know where's the safety limit. You have any answer to that, maybe from animal trials and so on?
So I think we're pleasantly surprised with other lithotripsy trials. There is a lot of safety, low dissection rate. You saw there was only one patient that had a dissection with the javelin. The 4.1% post-dilatation may be an issue with design. So it was mandatory to do a 1-to-1 balloon after the lithotripsy, where in reality you may actually do further lithotripsy to modify that, and you may be able to reduce that dissection rate post-dilatation if you treat it further at that point, instead of going straight to a 1-to-1 balloon, which I think in some lesions may be more aggressive than you want to be.
I think way more to learn about it, right?
What's that?
Way more to learn about it.
Yes, a lot of experience to be gained for sure. It is commercially available, and we've done some commercial cases as well with similar success. So very exciting.
So on that note, JD, tell us a typical case where you think this is where you're going to pull first. Like, are you try to advance a balloon, it doesn't cross the lesion, so you pull this, or are you going to use it as a primary strategy? We say long calcified, I'm going to make my channel.
So good question. So the EA catheter is more deliverable than the previous technology. So that is better as far as deliverability. So the obvious area to use this is in that difficult to cross lesion where you can affect the cap and cross it. But I think this will gravitate towards tibials, where you just primarily treat the whole tibial and then follow up with IVUS and then balloon angioplasty after it's been modified. But it does have a role in I think, SFA POPs. As we saw in this trial, the majority of patients did have disease in SFA POP, but again, depending on what our experience is moving forward, we'll see how that fits into the algorithm.
Yeah, do you see this as primary your crossing catheter, and I guess a lot of these particular tibial cases end up being subminimal. Do you think this device will be useful even if you're seeing that guide wire loop a little bit? Do you press on, or what's your experience so far?
I think so. You may not, if you're outside the calcified lumen, you may not get as much effect on the lithotripsy, just like with a balloon catheter, but I think the safety is there. I don't think you're going to have any higher risk going through that lesion, but I think you will get some benefit as well.
Wonderful. Thank you very much, JD. Congratulations.
Thanks, Eric. Appreciate it.